topic which we are taking today is role of adjuvants in poor responders. So all of us, we keep seeing that so many adjuvants are coming in market, and all companies, they kind of keep on promoting one product after the other. One product comes with 100 names. So we are really, really confused. So we thought that we will discuss about which adjuvants are supported by evidence. So just to give you all an overview of poor responders, what all we should be knowing is how do we define poor responders, what are the various causes of poor response, then are there any predictive markers, can we really predict the poor response, then what are the various treatment options and the adjuvant therapies. So whenever we stimulate a patient, stimulate means when we are giving stimulation injections, hormonal injections to our patients for ovulation induction, we always expect that there should be a normal response. But most of the time, surprisingly, it's not always a normal response. Sometimes it is no response at all. Sometimes it is poor response, and sometimes it is hyper response. So in literature, there are defined criteria for defining poor responders. So one of very well known and very old criteria is Bologna criteria by ASHRAE consensus, and this says that out of these 3 points which are written here, any two, like advanced maternal age more than 40 years or any other factor for poor ovarian response, then previous poor ovarian response in form of less than 3 eggs with conventional stimulation, like I did a stimulation last month and my patient had only 3 eggs or lesser than 3 eggs, that is another criteria. And third is abnormal ovarian reserve biomarkers, in the sense that antral follicle count is less than 5 or AMH is less than 0.5 to 1.1 nanogram per ml. So out of these 3 points, any two if are there, then we say by Bologna criteria, this patient qualifies to be called as a poor responder. So unlike this Bologna criteria, the new criteria which have come up is Poseidon classification. So Poseidon classification basically, helps us to report our patients uniformly, more uniformly, because that is a wider one. The Bologna criteria, if you say, it doesn't say young patient, like young patient can also have a poor response, but that says more than 40 years old, right? So Poseidon classification came into picture, which is more clear, and there can be uniformity in reporting. So collecting data and all that has become easier when it comes to poor response. So what is Poseidon classification? So Poseidon classification basically has 4 groups: group 1, 2, 3, and 4. And I always tell my fellows that the easiest way to remember this is the upper 2 group, group 1 and 2, they are unexpected poor responders. So unexpected means whether they are young or old, but they had good reserve. So we thought they will respond good, but there is an unexpected poor response. So that is group 1 and group 2. So group 1 is younger one, group 2 is older one, old girl, but with a good reserve. We expected that she'll respond good, but she did not. So that is group 2 Poseidon. Then group 3 and group 4 both are expected poor responders. So why I am emphasizing on this is because when we will come to adjuvants, which adjuvants in poor responder can be used, then there is an implication of knowing this group well. So that is why I am explaining it in detail. Group 3 is young expected poor responder, means she has a low reserve, and although she is young age, less than 35, but still her reserves are low, her antral follicle count is low, her AMH is low, and we are expecting a low response. Group 4 is old expected low reserve case. So these are the 4 groups as per the newer Poseidon classification, which is not new now, many years old, but still this came after Bologna criteria. So before we actually go to the topic of discussion for today, that is role of adjuvants in poor responder, let us briefly revise about ovarian reserve. What is ovarian reserve? So ovarian reserve is defined as number of oocytes remaining in the ovary at any given point of time, or oocyte quantity. And it is different from quality. Why we say so is because even at younger age, sometimes, you may have more eggs, but the quality is not good. So that's why when we say ovarian reserve, we usually talk about the quantity. So ovarian reserve correlates inversely with age, but there is a considerable variation in ovarian reserve among women of same chronological age with different ethnicity. So what I mean when I say this is, like European population, they behave better. Like my 40-year-old Indian girl is going to behave with a lesser reserve or poor reserve as compared to the same age Caucasian girl. So this is what ethnicity is all about as far as the ovarian reserve is concerned. So all of us know that at 20 weeks of age, when the girl is inside the womb of her mother, she has got the maximum number of follicles, and these start decreasing after 20 weeks of age inside the womb itself, and at birth it decreases to around 1 to 2 millions. Then at puberty it is around 3 lakhs, then 25,000, and the girl ovulates around 500 times throughout the life cycle. So there is a continuous atresia of follicles with age. Maximum follicles are at 20 weeks of pregnancy when we are inside our mother's womb, and around 3 lakh to 5 lakh at puberty, and only 500 will ovulate till menopause. Now, although this ovarian reserve testing is not the talk for today, but let me tell you that if we want to classify the different ways of seeing ovarian reserves, then this is the table which classifies how we can see what ovarian reserve somebody is carrying. So there are biological, biochemical, biophysical, and histological ways. And out of these, the red ones, the ones which are marked in red are the ones which are most sensitive. The age, then FSH level, AMH, and antral follicle count. So no matter what, age is the best predictor of outcome. So even if a younger girl has got lesser reserve, she is going to behave much better as compared to an older girl with a lesser reserve. So what are the various etiological factors of poor ovarian reserve? First is low follicular stock at birth. I mean, the girl is born with less stock. Then accelerated atresia of existing number of follicles. There is faster atresia. So there are some conditions where there can be a faster atresia. Then low follicular response or sensitivity to endogenous or exogenous gonadotropin, and low bioactive FSH. Then what are the conditions where accelerated atresia can happen? So there are immunological causes, and there is something called as autoimmune polyglandular syndrome, type 1 and type 2. So here what happens, there is gonadal affect, the gonads are affected because of these connective tissue disorders. So in type 2 autoimmune disease, there is Addison's disease. Then in one, there is mucocutaneous candidiasis. I mean, the multiple organs are affected, and along with the gonads are also affected. Then there can be sometimes the infective pathologies, then metabolic disorders like galactose toxicity, which is a storage disease, then iatrogenic causes. I operated and did a surgical trauma on the ovaries, then endometriosis, unilateral oophorectomy, then chemotherapy, cigarette smoking. All these are iatrogenic, except for cigarette smoking. So these are some more causes. Then chromosomal causes like numerical and structural problems on the chromosome. Then FMR1 gene, we all know that these girls, they do have problems of low ovarian reserve. So if a young girl is coming to you with very low reserve, we should ideally be testing her for FMR1 gene as well. Now, another way to classify or look at the causes of poor ovarian reserve will be advanced fertile age, then after ovarian surgery, advanced endometriosis, obesity, previous pelvic infection, smoking, lifestyle, and post-chemo and post-cancer radiotherapy. So who are poor responders? What is the incidence? Approximately 45%. This is what the evidence says. But I think when sitting in our OPD, it feels like that more than 50-60% of the patients who are coming to our OPDs, they are poor reserve patients. For some reason, the incidence is increasing even in younger population because of so many factors which are, we can see nowadays. So because of lack of clear correlation between quantity and quality, different authors have suggested that poor responders per se do not represent a lower chance in success in IVF, with the age of women being the most important predictor. We must always remember that young patient, even if they have by biochemical parameters low reserve, values, even then they are going to show us better response. So young poor responders have a better success rate in comparison to old ones. This statement is very important while you are counseling your patients. So whenever a poor responder case is coming to me, first thing is, can I identify this patient or can I anticipate a poor response? Then if I have identified, then how do I optimize and individualize her controlled ovarian stimulation? What extra I can do in IVF lab, and can we tailor embryo transfer? So all these are not actually part of today's talk, but adjuvants, when we say in poor responder, that actually means identify and optimize. So we can say that optimization, yes, we talk about what all adjuvants we can use. So poor responders and ART outcomes, what all we see is they have impaired egg quality, they have reduced fertilization rates, they have reduced embryo quality and increased rate of miscarriages as well. So how can we identify these patients? So this is poor response is predicted before the first stimulation cycle, then appropriate planning of protocol can be made, and it helps us to limit the number of cycles cancelled and also to shorten the cycle. So what are the various predictive markers? If any old patient coming, it's very clear that I'll be, anticipating a low response. Then previous poor response. So that is why it is very important to open up the documents, the treatment details, how the patient responded in last cycle, if the patient is being referred to you from somewhere. Then any medical conditions, previous chemo as we discussed, and previous ovarian surgery. So all these things are actually predictive markers. And no doubt, if age is more than 40, then we are, it's a red flag that the response is going to be on lower side. Now, these ovarian reserve markers like AMH, inhibin. So AMH we know is produced by antral and pre-antral follicle, and with age, that is why, because these follicles, they decline in number, that's why AMH decreases. And inhibin also is produced by pre-antral, antral and early follicles. So what happens when these follicle number is less, inhibin is less, so there is a negative feedback which is normally there on pituitary will not be there, and hence there is a rise in FSH. So because of this rise in FSH, what happens is there is a faster recruitment of follicles, and there is a faster atresia of follicles. Now coming to the second best ovarian reserve case, ovarian reserve marker, which is antral follicle count. We know that nowadays by Sono, AVC and all, we can actually count. This is how the antral follicles, they look like on ultrasound, and it is almost standardized. All of us, we as IVF specialists, fertility specialists, we actually rely a lot on antral follicle count on transvaginal scan. And how you do it, how you count them is, it is done between day 2 to day 5 of cycle, and you measure 2 to 9 mm follicles and 6 to 7 mm size follicle. They give you the best correlation. So when we say best correlation means usually they grow well and finally give you mature eggs. So when we say management, so adjuvants is definitely we are going to talk about, but apart from that, if my stimulation is not optimal, then whatever adjuvants I add, it is not going to help. So it is very important that I optimize the stimulation protocol as well as the adjuvants when I am thinking of stimulating a poor responder case. So optimal stimulation remains a challenge and requires particular attention to achieve a good reproductive outcome. So when Cochrane review is seen, it talks about what are the optimum doses of gonadotropin, should agonist protocol be used or antagonist be used, then can we do natural cycles in poor responder, is it a good option, and then finally, yes, adjuvant therapies. What are various adjuvants? Now, various things which are discussed in regard to poor responders are, does high dose of gonadotropin help? Then GnRH agonist protocol, if you are using, is it low dose or you use a standard GnRH long protocol, flare up protocol, stop protocol or short protocol? Then what is the role of oral contraceptive, DHEA, testosterone, letrozole, growth hormone, adding LH and aspirin? So these are various discussions which keep happening in various articles about the poor responders. Now let's come to them quickly one by one. We will be focusing more on adjuvants and a few basic slides about the stimulation protocol, what evidence is saying. So evidence says that increasing FSH dose more than 300 units of FSH does not help. So we should not be giving a super high dose of FSH in these patients, and this is clearly not associated with better IVF outcomes. Then coming to the agonist, what does it say about agonist? So reduced dose of GnRH agonist or short flare-up protocol or mini dose protocol, they are favored because the literature says that ultra long protocol may give too much of suppression when we are continuously giving agonist to these patients. Then antagonist is a good protocol for these poor responders, and we will come to the evidence when it comes to the comparison between agonist and antagonist. But regarding the natural cycle, most of the articles do not support. I mean, if it is a case of poor responder, will I have good results if I leave my patient alone and do natural cycle IVF? So this is the question. So the literature says that natural cycle outcomes are really not good in these patients because there is hardly any we are not giving any stimulation in collecting eggs in natural cycle. So the literature does not support, the evidence does not support in favor of natural stimulation natural cycle IVF. So what do we mean when we say we should individualize our controlled ovarian stimulation? So one cannot stimulate the follicles that are not there. It is not so that if the quantity of oocyte is less, the quality is also low, and young responders, they conceive. So these are few points which we always have to remember when we are stimulating our patient. Agonist versus antagonist protocol, as I said. So when we compare these two, then literature says that you may get one, maybe more egg when you are using long agonist protocol as compared to antagonist protocol, but the live birth rates are same. So all fertility specialists, they really like antagonist protocol most of the time because it is patient friendly. You need not, kind of start stimulating your patient from the previous cycle. You can call your patient straight on the day 2 of periods, and it is very, very convenient. And if you compare the two, there is not much difference. That's why agonist as well as antagonist, both protocols as far as number of eggs, live birth rates are concerned, are same. Now this study, if we look at here, there is a fallacy if we see, because in long GnRH protocol, they used only rec FSH, whereas in antagonist, they used FSH plus R recombinant LH also. So we will come to the role of recombinant LH, but let me explain it to you that they say that when antagonist cycle was used with recombinant FSH and LH, the poor response chances was less. The eggs which were retrieved were more. Cancellation chances were less. Pregnancy were more reported. So this is what we talk about individualization. So probably there is a what we call it confounding factor here, because recombinant LH was used, but most of the studies say when you use agonist protocol, then, and if you compare it with antagonist, most of the time the final outcomes are the same. Now coming to the adjuvants in poor responders. So what all adjuvants? So adjuvants means add-on therapies. So what are various adjuvants which are discussed in literature? That is first question. So first is DHEA, then testosterone gel. Does it help or does it not help? Then LH supplementation, should we do? Then CoQ10. So market is flooded with CoQ. So should we be using it? Is there any evidence supporting the use of CoQ10 in poor responders? Then growth hormone, then addition of letrozole, and then estrogen priming. Does it help poor responders? And my talk, I think, would be incomplete if we don't touch on dual stimulation, because at the end of day, when we say adjuvants, why we are talking about it? We are talking about it to see that is the response or the final outcome enhanced. So similarly, we need to talk about does dual stimulation and all these things are also going to enhance the final results? Then does changing day of embryo transfer enhance the result? And is there a role of minimal stimulation? So let's touch on them one by one. So first thing is DHEA. So dehydroepiandrosterone. So how does it act? 1/3 of the fertility specialists in the world are using DHEA in poor responder. It is a crucial precursor for conversion of steroid to androgens or estrogen based on expression of steroidogenic enzymes present in peripheral target tissue, including ovarian follicles. So what is the mechanism of action? It improves steroidogenesis as a precursor for estradiol and testosterone. It influences ovarian follicular growth. It increases insulin growth factor 1, acts as pre-hormone for follicular fluid, reduces the chances of aneuploidy. So all this is written in literature that this is the mechanism of action of DHEA. If we look at dose, 75 milligram in 3 divided doses for 60 to 70 days is the ideal dose. So if you give it to your patient only for 15 days, it is not going to help. If you have decided, most of the time the problem which comes in poor responders is if they are at higher age, then we do not have much time to first give them DHEA for 3 months and then take them into the cycle. But young poor responders, we must give them this chance. DHEA may have a role, and there is a level 1A evidence which says that clinical outcome may be better and live birth rate and clinical pregnancy rates may be better. Now coming to CoQ10. So what is the mechanism of action of CoQ10? It is vital for ATP synthesis. So when we say ATP synthesis, we know all cells, they need ATP synthesis. So due to its redox property, it is useful for neutralization of reactive oxygen species, that is free radicals. And de novo CoQ10 production declines with age and coincides with age-related decline in fertility. So it is, the proposed mechanism is restoration of reactive oxygen species imbalance and preventing DNA damage. This is how it is going to help. But unfortunately, most of the studies are in normal responders. In poor responders, we do not have much data. So, but yes, in normal responders, there are many studies coming up which say that clinical pregnancy rates, even abortion rates, they are reduced. And the dose is 300 milligram twice daily for 60 to 90 days. So for poor responders, we do not have strong conclusive evidence. But otherwise, we have now ample studies. This is one study which says that Poseidon group 3. So you remember in beginning we discussed what are various 4 Poseidon groups. So Poseidon group 3, if you recall, the lower left group, which is young expected poor responder. It says that CoQ10 can enhance oocyte and embryo quality and response to stimulation in these patients as compared to other Poseidon groups. Then coming to transdermal testosterone. So testosterone gel pre-treatment increases the pregnancy rates and embryo quality, but there is no significant improvement in OCCs, means oocyte cumulus complex, which is retrieved after daily application. Doses are 1.25 gram gel per day for 20 days. So it is used in previous cycle. So similarly, all these testosterone derivatives, we have to stop when we start the stimulation. This is very important. So testosterone gel is also given in the previous cycle. Then coming to growth hormone. So possible mechanism of action of growth hormone include increased production of insulin growth factor and growth hormone used along with gonadotropin. When used in patients with poor ovarian response, increases total number of eggs, total M2 oocytes, transferable embryos. So this is the evidence. What is the dose of growth hormone? 4 to 8 units from day 2 of stimulation till the day of trigger. Now letrozole. Does letrozole has a place in for poor responders? So there are few skeptical studies which have really supported its use in poor response cases, and how it acts is by increasing precursor androgen, by upregulating follicular FSH, and it makes follicular growth hormone growth more sensitive to stimulation. So this is the mechanism of action of letrozole. I have also used letrozole recently in few poor response cases and it is working well. Now recombinant LH. So there was a slide in between where we talked about recombinant LH. So most of the studies, they say that there is no significant difference in number of eggs retrieved and total dose of recombinant FSH used, total duration of stimulation after using recombinant LH. But I found a very nice article on role of recombinant LH which says that The recombinant LH helps in certain situations and certain conditions. So what are these conditions? It really helps in advanced maternal age. Then it helps in hyporesponders. So hyporesponder basically is Poseidon 1 and 2. Both are hyporesponders. Then it helps in poor responders Bologna criteria with severe, severity of poor response as per Bologna criteria. There it is going to help. And hypogonadotropic hypogonadism, there also it is going to help. So how it acts is, it acts at the follicular level in a dose-dependent manner. It increases androgen production, and androgen is then aromatized to estrogen. So the follicular milieu, it is much better when you use recombinant LH in these cases. So again, I think this slide we have already discussed that when you use recombinant LH with FSH, so there are studies which are supporting that oocyte number, then pregnancy rates, they are better in poor responder cases. Now, this study is an Indian study by Dr. K.D. Nair and team. So I will, I will suggest all fertility specialists and whosoever is interested to take a click of this article and read it. It's a nice article, very nicely written, and they have included all the, kind of situations as far as poor responders are concerned. And if we look at the evidence regarding the adjuvants, so see, adjuvant use of growth hormone in ovarian stimulation is not recommended, strong recommendation. Similarly, testosterone also not recommended, conditional recommendation. DHEA not recommended, strong recommendation. Coenzyme Q10 not recommended. As I said that it is mainly for poor responders. There is again a strong recommendation. So you can all look up at this article. But when I say all this, then we are again confused that should we be using some adjuvants or not. So then this is a very beautiful, again, a systematic review and network meta-analysis from where I have picked up this chart, which is going to help you all in understanding that out of all the adjuvants which we talk about, so literature says that, 1, 2, 3, and 4. So these 4, DHEA, then CoQ10, then growth hormone, and testosterone gel. So these are the ones which are little supported. But, if you ask me, there is no very strong evidence to say that this particular thing or adjuvant is going to give you, significantly higher results as far as pregnancy outcomes and final pregnancies are concerned. But yes, DHEA, testosterone gel, then growth hormone when you add during stimulation. DHEA and testosterone is in the previous cycle, growth hormone is in the present cycle, and CoQ10 given for 2 to 3 months, that is going to make the difference. Now again coming to individualization of controlled ovarian stimulation. So REC-FSH means recombinant FSH and REC-LH and GnRH antagonist protocol is going to give you good results and outcomes. Now, when we talk about minimal stimulation, there are so many types of minimal stimulation, like you give clomiphene from day 2 to 9, you give low dose of maybe Menopur or FSH. Similarly, this is one protocol where letrozole given and then CC. So minimal stimulation evidence does not support much in case of poor responders. And they say that we do not, most of the time it is kind of a wastage of resources. This is what they say, that say no to mild ovarian stimulation for all poor responders. You really have to see, sometimes if my patient is showing just one follicle and there is no follicle in other ovary and single follicle all the time, that may be a case. Otherwise, if your conventional stimulation gives you even one more oocyte, then we should be going for that. So also in mild and moderate stimulation, higher cancellation rates are seen. That is why it is not preferred much. But few, clinicians, they are very pro for this. I'm not sure whether Nisha is sitting here or not. She gives a lot of minimal stimulation. So let's hear from her. And as far as embryo transfer is concerned, we have to customize, we have to individualize where day 2 is going to give benefit or blastocyst is going to give more benefit. And they say that minimal stimulation blastocyst ET is better, whereas in conventional, if it is a real poor responder, day 2 transfer also is sometimes preferred. Then coming to dual stimulation is based on the fact that there are multiple waves of follicles coming up in the same cycle. So one wave you use.
Am I audible?
Yes, yes.
Yeah, I would just like to ask you, what is your experience about using this growth hormone? Personal, what is your experience?
So my experience is growth hormone is doing good. And when we add it, judiciously, where the response is little subtle, it suddenly shows you a better, improvement in the follicular growth. I won't say that the final outcomes are good, but yes, the number of eggs retrieved becomes better in poor responders. And we can take
that is
opinion
what
from
exactly even I found, that the follicular growth was good. We were able to retrieve, but embryo quality was finally bad, and I didn't find any much good quality embryos. Only the
I won't say that because of growth hormone the embryo quality goes bad, but yes, the follicular growth, if it is stunted and if you add growth hormone, so then yes, this is the experience that they start growing better. But yes, we have really not correlated it with the final outcomes in form of pregnancy outcomes. So difficult to say, as literature says that the final outcomes are ultimately the same. We can request Brigadier Sharma sir for his comments on growth hormone.
Yeah, see, I have used growth hormones in quite a number of patients, but I did not find any good result. So I stopped using it as an adjuvant because it just increases the cost. That is one thing I have found. Now, another thing is that what about some antioxidants like vitamin C and E, which are very cheap to be given to these patients? What's your view on that?
So definitely vitamin D has got, I should have put vitamin D at least here, because vitamin D has a proven role for egg quality. C and E routinely I don't give, but then A is a strong antioxidant, and similarly C is also a strong antioxidant, and it's very cheap tablet, right? As far as price is also concerned. Sir, are you using it routinely for your patients?
Yeah, see, as far as vitamin C is concerned, nowadays, since amla is available in quite a number, so I encourage my patients to take as much of amla as possible, and vitamin E I give them. Yeah.
Right. Dr. Seema is there. She can give her comments. Dr. Shalini, Dr. Seema.
Dr. Sunita, it's a very crisp talk. I mean, not only for the adjuvants, you very well covered it right from the beginning. So I think you have very clearly highlighted the role of adjuvants. The only thing I feel that about the DHEA is that when it is given too much, it is like a hyperandrogenic condition.
All right. So these girls, they are lacking androgens in their follicular fluid. So probably I personally feel that 3 months of DHEA, whenever you feel that you have to give, then that has to be given. But more than that will help or not, that is really a question mark.
I think the women now we are seeing, it's mostly in the age of even 31, 32 years, and they come with such a low AMH and AFC. So in these, even we are giving for 3 months, and after 3 months at least we are seeing some improvement in AFC.
Yeah, so I will say that, individualized cases have shown improvement, but there is no uniformity that everybody who is given DHE, everybody doesn't show a response. So that's the point, but sometimes it really helps.
I said in group 3 we can easily give.
Yes.
Because now we are seeing many women coming, 31.
Even for CoQ10, they have said that group 3 Poseidon gives you, a better outcome if they are given CoQ10. Do we have any more questions? Otherwise, we will move on to the next topic.
Yeah, I think just move on. Yeah.
Just one second. Dr. Sunita, before giving DHEAS, do you do the levels of DHEAS and testosterone as a routine?
No. I don't do. Shalini, are you doing?
No.
Okay.
And
So
in
when
fact,
the
we
AMH,
have to weigh the, I mean, yes, agreed in group 3, where age is less, AMH is less. Because, in group 4, where the ovarian count is less, where the age is also advanced. So I think we have to weigh the pros and the cons, because we don't want to lose even 3 months there, because time is very precious. So maybe in group 4, I would be skeptical to use DHES, but yes, in group 3, certainly in young patients, we can use it, and not for more than 3 months. That
And
would be
in this
my,
young patients also,
yeah,
I would divide them into two subgroups.
yeah.
One who are having hirsutism. Nowadays, you find the lot of maybe due to dairy products or something, they have a lot of acne and they have hirsutism. They are not PCO, they are poor responders. Now, in those patients, I would not like to give DHA. It's only the other group which doesn't have too much of hirsutism or it doesn't have acne and a poor responder. There, I would like to give the DHA.
correct. Anything else? Anybody else wants to discuss anything?
So what about dual stimulation in the cases of such that you are talking about acne and hirsutism patient? I think they work more better if we give them dual stim in these cases.
Yeah, because
Rather than DHEA, we do this, that first we take out whatever we get and then we do the dual stimulation.
you're talking about the poor responders.
Yeah, poor responders and especially these hirsutism patients, acne hirsutism patients.
Yeah. Now the thing
Why do you think, Dr. Kavita, acne hirsutism patients are going to respond better in dual stimulation?
Ma'am, actually, we have seen either there were some LH pleomorphism defect in these patients, they were not responding to anything, and they had quite a good number of AFC. And when I stimulated them, I've seen 2-3 patients like that. We were only able to get only 2 embryos, and on the day of retrieval also there were many AFC, and they were around 13-14 mm. So we just retrieved that, gave a gap, and then we started with the luteal phase stimulation again, and again we were able. So we did the embryo pooling.
So have you compared them with those patients who do not have these androgenic features? And do you feel that there is
we haven't done any comparative study yet, but yes, when I came across, we could see there are so many 13-14 mm. There were 5-6 AFC of 13-14
So
mm.
I think that is good for any case, of poor responder where you are seeing too many follicles, but the final outcome, output ratio is less. Then you can again stimulate, irrespective of whether they have hirsutism and acne or not, isn't it?
Yeah.
were they having high AMH levels?
Sir, AMH was 1.5, 1.6, like that.
Because
They were
sometimes
not actually coming into poor responder, but
sometimes
AFC.
very high AMH. Also, they have anyway androgenic features, but they are poor responders.
Yeah,
So
exactly.
they would do better on the second stimulation.
Yeah.
So should we move on to the case presentation?
And just one comment, if I'm allowed to make, you should always rule out ovarian cysts. I have seen with DHEA, these cysts tend to enlarge, which is understandable because estrogen is increasing in the body. So just this is my experience I'm sharing.
Yeah, you are right, Preeti. Sometimes, when you give 2 to 3 cycles of DHE and the patient comes all ready for stimulation, then you will find a cyst there. So I have also observed this, that DHEA leads to increased chances of, forming these cysts and all. Very good.